everyone, I'm Dr. Dhavasree, one of the mentors at StudyMEDIC, and this is another video on the Vishnu, sorry, stop it. This is RRR series, no? Vishnu?
Hello.
Vishnu, can we restart it again? Is that okay?
Yeah, man. This is Kickstart series, right, ma'am?
This is RRR. Sorry, this is Kickstart. Oh my God. This is a Kickstart series.
Yeah, I think RR is for EBCOG.
Yeah, EBCOG. Okay. So you can start from, you can edit, no? Will that be possible?
Yeah, yes, ma'am. We can edit the video, ma'am. We can cut the video.
Yeah. Okay. I'll start off from now.
Okay, ma'am.
Hello, everyone. I'm Dr. Dhavasree, one of the mentors in StudyMEDIC, and this is another video from the Kickstart series for the Part 1 candidates who are preparing for the Part 1 exams of MRCOG. And in the physiology, the topic that we are going to see is acid-base balance. Whenever we think of acid-base balance, we always get a jitteriness when we try to work on the cases. So let us get through the concepts and make our concepts clear so that we would be able to work out the solutions of the given situation. So I would be dealing with, we will see everything about acid-base balance in this video. And before we start, there's certain things which we should remember. The beautiful thing about learning is that nobody can take it away from you. And this is one very important thing, especially for the acid-base balance. Once you know, you will never forget it. Okay, so let us get through the concepts, and the agenda of the session is we will know about the basics, the pathophysiology of acid-base, abnormalities of acid-base disorders, and we will have questions to solve. So with that, let us start into the session. The introduction of, we all know, is a normal pH for a human is around 7.35 to 7.45. Okay, so this is the range at which a normal pH is there, where the body fluids pH is between 7.35 to 7.45. And if it is less than 7.35, then it means it is acidosis. Okay, anything which is less is acidosis, which is nothing but an increase in the hydrogen ion concentration. If the pH is above 7.45, then we call it as alkalosis, and that happens because when there is less of hydrogen ions. So this is a simple thing which we will have to remember before we start the acid-base balance. So we know between 7.35 to 7.45 is a normal range. It is a normal pH range, below which it becomes acidosis, and above 7.45 it becomes alkalosis. But there is certain area beyond which the human may not survive is if it is less than 6.8, and if it is more than 8, the chance of survival is very less. So the survival range of pH for a human being is between 6.8 to 8. So this is about a basic introduction about pH and things we have to know about acid bases. What does it mean by an acid? An acid is anything which donates a hydrogen ion. For example, a strong acid is a hydrochloric acid, and it completely dissociates into hydrogen and chloride ion, thereby giving hydrogen ions. And H2CO3 is a weak acid which has an incomplete dissociation, which gives hydrogen plus HCO3. Okay, H plus ions plus HCO3. So with this in mind, what does a base mean? A base is anything which accepts a hydrogen. So hydrogen HCO3 is a base which accepts the hydrogen ion and becomes a carbonic acid, that is H2CO3. This is a reversible reaction. H2CO3 dissociating into H plus and HCO3, and HCO3 can act as a hydrogen acceptor, and HCO3 is a base. There are other bases which can accept hydrogen ions, that is NH3, this is ammonia, NH3 plus H plus will form NH4. So this again, NH3 is a base which accepts a hydrogen ion, thereby becoming ammonium ion. So with that, acid and base, when we have acid and base, there should be something called a buffer because we need a range between 7.35 to 7.45. So when there is an increase or decrease, there should be something which buffers this so that the balance is maintained. So any solution which resists the change in pH is called a buffering solution. What are all those things? Before we think of an buffering, so what happens when normally there is a process of metabolic changes happening in the body, that there is always a bit of acid which is produced in the body. So in the body, there is an alkali reserve, which is nothing but a bicarbonate. And this bicarbonate is in a higher concentration so that it overcomes the acid. Okay, these acids are constantly synthesized in our body. And so there is always a reserve in the body, which is approximately 20 times higher than that of an acid. And so when the acid increases, this alkali reserve is able to get over this metabolic this acidosis. So this is exactly the alkali reserve is a little higher than that of the acidic concentration. And we all have to remember the HCO3, which is there in the body, is around 24 millimoles per liter. For us to have a range, it is 22 to 26 millimole per liter. So pH is nothing but the log of H plus ion. So inversely, pH is inversely proportionate to the hydrogen ion. So when the hydrogen ions increase, the pH decreases. So this is the same thing that we will have to remember. Okay, the pH is nothing but the log of hydrogen ions, or the inverse of H plus, which is when the H plus increases, the pH decreases. Okay, hope it is clear so far. Okay, with that, we then have to remember one thing, which is called a pK, a constant called a pK, which is nothing but a pH at which the salt and acid, the product is half ionized. That is, the salt is to acid should be in a range of 1:1. And for us to remember, the most effective pK values are close to the normal body pH. So basically, what we will have to remember is for a pH to be maintained in a body, we will have to remember a Henderson-Hasselbalch equation. Okay, what is this? It is the pH value that is derived from the pKa value and a log of the bicarbonate divided by the acid, divided by the H2, the carbonic acid. Okay, so the concentration of the base is on the top, and the concentration of the acid, that is carbonic acid, is on the bottom. So basically, this reaction helps us to know that if we see the pH basically depends upon the ratio between the bicarbonate and HCO3. That is basically the carbon dioxide. H2CO3 is formed from carbon dioxide and water. So basically, the pH is a function of ratio between the bicarbonate and the carbon dioxide. So the numerator here, HCO3, is under the metabolic control, whereas the denominator is under the respiratory control. So PCO2 basically is determined by the respiration, and HCO3 is basically determined by the metabolic control. So we have to remember this. These are the two things which will actually maintain the pH, HCO3 and carbonic acid. So with this in mind, let us move on to the buffers. So when the acid increases, the base has to, there should be a buffer which actually normalizes the pH. So when the acid increases, the pH decreases. That is acidosis, in which case the body has buffer systems in the body fluids, which will actually overcome the acidosis or alkalosis. So there are three basic principal buffers in the body fluids. One is the blood. In the blood, it is the carbonic acid. So carbonic acid is, it's a both the way reaction. H2CO3 can dissociate into hydrogen and bicarbonate ions. Again, hydrogen and bicarbonate again can be joined together, combined together to form carbonic acid. And it is similar to that of, there's one more blood buffer, which is the protein buffer. The protein buffer again is a major buffer. It is extensively present in the body. So in the blood, there are a protein buffer, there are hemoglobin buffer, and a carbonic acid buffer. So the most common buffer is a carbonic acid buffer, okay, in the blood. And in the interstitial fluids, again, it is the carbonic acid, which is the most common buffer that is seen. And in the intracellular fluid, okay, within the cell, it is the protein and the phosphate buffers, which act in a higher way so that it balances the acid base produced in the cells. So with this, we shall move on to the buffer systems commonly where it is seen. Bicarbonate buffers, as I said, they are the most important buffer both in the extracellular and the, so if this is in the blood, extracellular, and in the intracellular. So they are the most common buffer which act in the body, whereas phosphate buffers are most important buffers in the inside the cells, and protein buffers are the largest buffers store. Okay, so they are the largest buffers that are present in the body. And in the extracellular fluid, it's the albumin and the globulin which form the buffer system, whereas in the intracellular fluid, it is a hemoglobin and the protein anions in the tissues that forms the buffer system. So remember this, and with the buffer system, these buffer systems are very, very important in having an acid-base balance. Okay, so when there is an acid-base imbalance, okay, what is that maintains the balance is that there are three, usually what happens immediately when there is a change, there is a first line defense which comes into action, which is a very immediate action which happens in few seconds. Okay, this is the blood buffer. They are already present in the tissue and will handle the minor changes in the acid-base balance. So this chemical buffers or the blood buffer, which are the most important first line defense against the acid-base imbalance. If this, once this comes into action, the second line defense also if necessary, would come into action, which is the respiratory mechanism. So what happens? The second line defense is that the respiratory, either this carbon dioxide, respiration is basically, it modulates the PCO2. So either it retains carbon dioxide or it hyperventilates or it eliminates the carbon dioxide so that it maintains the pH. So this happens within minutes, and this is a compensation which can handle a mild to moderate acid-base shifts. The third line defense mechanisms are the renal mechanisms. Okay, this takes a little longer time than that of the other things. Here, basically, the renal is, they regulate the bicarbonate. Okay, so they regulate, either they absorb bicarbonates or they secrete bicarbonates, thereby they combat the hydrogen, either the hydrogen ion loss or the K. Okay, so usually it starts in hours, but this is the, they are the more permanent acid-base balance that can happen. And usually this completely, within hours it starts, but it completely sets in 5 days. Usually it is little longer time. It takes a longer time, but they are the permanent compensatory mechanisms. I hope it is clear so far. Okay, so let's move on to what happens when an acid-base balance occurs. So as I said, acid-base balance is addition of acidosis is addition of hydrogen ions. When there is an hydrogen ion added to the body fluids, there is an increased H plus anion. So there is increased H plus anion, which is there in the blood, and we always have a reserve. Okay, this is the bicarbonate reserve. So usually it is a sodium bicarbonate, which is there as a reserve, which actually once there is an increased hydrogen ion, which is added, the sodium and the bicarbonate, they separate, and HCO3, the bicarbonate ion, is pushed into the blood so that they combine with the hydrogen ion, thereby causing H2CO3. This hydrogen ion again are a good strong stimulant of the medulla, which causes hyperventilation. Thereby, this carbonic acid again is converted into hydrogen ion, water molecule, and the carbon dioxide, and carbon dioxide is exhaled through the lungs. Okay, so by this mechanism, the the hydrogen ion concentration is reduced. This happens within few seconds. Okay, the next the within minutes, the lungs, the carbon dioxide is the HCO3 from the reserve comes in. This happens in seconds, and the carbon dioxide is pushed out. This happens in few minutes. And the other mechanism is a renal mechanism. What happens is that the kidneys secrete more of hydrogen ions or retain bicarbonate, so that they come to the alkali reserve, and this maintains the hydrogen ion. This maintains the pH, thereby the hydrogen ions are bound to the HCO3, thereby causing a normalization of acid-base balance. So this is a response of acidosis. And there are other buffer systems that can absorb H plus, like that of a protein. All those other systems do absorb hydrogen ions, phosphate buffers, and protein buffers, and hemoglobin buffers. They all can absorb this hydrogen ion, thereby reducing the acidosis or reducing the hydrogen ion concentration. Okay, this is the response that happens. So when there is an acidosis, the hydrogen ions combine with the HCO3, thereby producing carbonic acid. And carbonic acid is again split into carbon dioxide, which by hyperventilation is exhaled. So the hyperventilation is a compensatory mechanism which happens to overcome the acidosis. Okay, so what happens when there is an alkalosis? Basically, alkalosis is when there is a loss of hydrogen ions or gain of bicarbonate. Okay, so when the bicarbonates, when the hydrogen ions are removed from the blood, what happens is we need more of a HCO3. Alkali is required. So what happens? The H plus, reduced H plus, causes the medulla causes the suppression of the respiratory center. Thereby, the respiration is reduced. So carbon dioxide is retained, and this causes carbonic acid. So when the carbonic acid is again split into HCO3, which combines what happens is when the carbon dioxide level increases, okay, it increases the carbon dioxide level, thereby increasing H2CO3, and H plus ions are so alkalosis is overcome by addition of hydrogen ions. When there is an HCO3 is high, so what happens? H2CO3 is divided, is separated as H plus and HCO3. This H plus ions again, when there is a H plus ions are removed, that is added, and HCO3 increases, which can combine with that of the hydrogen ions. And the other thing is the kidneys generate more of hydrogen, and they secrete more of HCO3, thereby alkalosis is taken care. So the compensatory mechanism when HCO3 is added or when H plus is removed is that carbon dioxide is retained and the human has hypoventilation. So H plus ions, reduced H plus ions causes suppression of the medullary respiratory center. So with this, if these are the respiratory, these are the compensations which happen when there is an acid-base imbalance. So what are the types of imbalance? There are 4 types of basic types of imbalance. One is metabolic acidosis. The other one is metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Let us go into each one separately. How does it happen? Arterial pH, we all know it is 7.35 to 7.45. When it is decreased, when the pH is reduced, we call it as acidosis. When the pH is increased, we call it as alkalosis. So acidosis can happen when there is an increased PCO2, which is nothing but carbon dioxide is basically when it increases, it causes more of acidemia. So when we talk about carbon dioxide, it is respiratory acidosis. There can again be acidemia by reduction of HCO3. Reduction of HCO3, when we talk about HCO3, okay, bicarbonate ion, that when that is reduced, there is more of H plus, and so this causes metabolic acidosis. So metabolic acidosis happens when there is reduced bicarbonate. Respiratory acidosis occurs when there is a raised PCO2. Okay, it is the vice versa for alkalosis. In case of alkalosis, when the PCO2 reduces, okay, automatically, if we talk about carbon dioxide, it is respiratory. When there is an reduced carbon dioxide, there is reduced of H plus ions, and thereby it causes respiratory alkalosis. Okay, and when there is an increased bicarbonate ion, it is basically, when we talk about bicarbonate, it is basically metabolic, and when the bicarbonate increases, it is metabolic alkalosis. So these are the 4 types by which there can be an acid-base balance. Normally, there can be simple acid-base balance, but there has to be compensatory mechanisms which takes care of this imbalances. So we will deal with all the simple acid-base balances. Okay. So in a nutshell, normally what happens in a metabolic acidosis, we have to talk about if the pH is reduced, that is nothing but hydrogen ions are increased. Metabolic is basically HCO3. So the primary disturbance that happens is HCO3. Okay, there is a reduced bicarbonate ion which increases the hydrogen ion, thereby reducing the pH. Okay, in metabolic alkalosis, again it is in regard with that of bicarbonates. So metabolic alkalosis is there is a less of hydrogen. That is because of more of bicarbonate. Okay, when there is more of bicarbonate and less of hydrogen, and the pH again increases. Okay, so in metabolic alkalosis, the pH is high, and the primary disturbance is bicarbonate is high. Okay, whereas in case of respiratory acidosis, the pH is low, the hydrogen ions are high. When we talk about primary respiratory, it is only PCO2 which we have to talk about. So the PCO2 is high, thereby increasing the hydrogen ions, thereby reducing the pH. Whereas respiratory alkalosis, again, the pH is high, but when we talk about PCO2, the PCO2 is reduced. Okay, and the pH is also reduced. In alkalosis, the pH is high and the hydrogen ion is reduced. So here, how do we remember these things is that it is very easy with a mnemonic called a ROME. So when you see ROME, okay, in respiratory, always respiratory, we'll have to talk about carbon dioxide, okay, and we'll have to talk about the pH. These are the 2 things. So when we talk about respiratory, these are the 2 things which we will have to see. pH, when it reduces, what we call it as acidosis. Okay, when the pH reduces, and in case of respiratory, it is always in the opposite direction. So when the pH reduces, the carbon dioxide increases. So if you see, when the pH reduces, the carbon dioxide increases. They go in an opposite direction. That is what is in respiratory, the two things will be in opposite direction. Okay. Whereas in case of metabolic acidosis, we talk about pH, and if it is metabolic, it is HCO3. So when we talk about pH and HCO3, and if it is metabolic, then both of them will be in an equal direction. So when the pH increases, the HCO3 increases. So if you see, when it is metabolic, if metabolic acidosis, the pH reduces, automatically the HCO3 also reduces. Okay, this is an easy way to remember the what happens in respiratory, what happens in metabolic. So when we talk about metabolic, we talk about the pH and HCO3. When we talk about respiratory, we talk about pH and PCO2. So this is exactly what is given. If the pH increases, it goes in an opposite direction. Okay, the PCO2 reduces. When the pH increases, it is alkalosis. Okay, when the pH reduces, it is acidosis. What happens in a respiratory acidosis? The PCO2 increases. Hope it is clear so far. Just again, just a quick refreshment. If the pH increases, we call it as alkalosis. Okay, and when if we have to think about metabolic, we think about HCO3. So it is Me is metabolic, it is on the same side, that is equal. So when the pH increases, HCO3 also increases. When the pH decreases in metabolic acidosis, the HCO3 also reduces. Okay, so with this, this is just to remember, this mnemonic is just to remember how these two things happen. Okay, what happens in those values. This is just to remember for in the exams, so that we can quickly have a remembrance. Okay, so what are the etiology of the different disorders? We are going to talk about only simple disorders in respiratory acidosis. Respiratory acidosis is basically hypoventilation, where there is there is inadequate breathing or hypoventilation. So hypoventilation, paralyzed or a weak respiratory muscles, narcotic overdose, drowning, cardiac arrest, and loss of consciousness. All these things can cause respiratory acidosis due to inadequate breathing. Whereas respiratory alkalosis is basically it is the opposite. Okay, so they hyperventilate, thereby, this happens in panic attacks, in ASA, early overdose, sometimes high altitude, brain injuries, asthma, respiratory alkalosis happens. So what happens? They have ineffective breathing and they hyperventilate, and it results in respiratory alkalosis. What happens in metabolic acidosis? There is too much of hydrogen ions. This can happen in diarrhea, renal disease, diabetic ketoacidosis, excessive alcohol intake, and the late stages of ASA overdose. Okay, and in case of severe dehydration. In case of what happens in metabolic alkalosis is there is a loss of hydrogen ion, usually through the body fluids, like that of vomiting, gastric suctioning, antacid ingestion, excessive aldosterone, diuretics. All these things can cause metabolic alkalosis. Okay, we're not talking about mixed acid-base disorders because it is a complex one. Usually, normally what we get in the exams is all straightforward, simple acid-base disorders. Okay, so this is exactly what we have been seeing so far. When there is an abnormal, this is metabolic acidosis. So hemostasis, the metabolic acidosis can be disturbed. Okay, in acidosis, what happens? The hydrogen ions increase, thereby pH reduces. So there is an increased hydrogen ion production or a reduced hydrogen excretion. So basically in the body, in the blood, there is an increased hydrogen ion concentration, which can decrease the pH, or there can be a bicarbonate loss, okay, like that of a diarrhea, where the bicarbonate depletion occurs. Okay, this again reduces the pH. Okay, there is an increased hydrogen ion concentration, thereby reduced pH. And what we spoke about was the immediate thing is the the buffer system, the carbonic acid buffer, which comes into action. Then comes the respiratory compensation. This, when there is an increased hydrogen ions, there is an increased respiratory rate, thereby the PCO2 is reduced. So carbon dioxide is exhaled, thereby there is an this pH is compensated. Hydrogen ions reduces, thereby pH is compensated. And the other mechanism is a renal compensation. This is what we have seen before. And just a quick brush for again, metabolic acidosis is when there is an metabolic alkalosis, when there is an increased increased bicarbonate ions. It can be due to loss of hydrogen ions also. So when there is an increased HCO3, the first thing that happens is a bicarbonate buffer. Okay, usually the bicarbonate buffer is the immediate buffer, followed by the respiratory compensation. What happens in the respiratory compensation? When HCO3 is reduced, the carbon dioxide is retained. We have to retain carbon dioxide. So there is an hypoventilation which causes increased PCO2, thereby compensating the HCO3, H plus ions, and which increases the hydrogen ion, thereby reducing the pH. Okay, and the other renal compensation is hydrogen ions are more produced to compensate the H3O bicarbonate ions, and the HCO3 is secreted more by the kidney, so that there is a reduction in the HCO3 concentration in the blood. So these are the buffer systems which activate when there is a metabolic alkalosis. So in case of respiratory acidosis, basically when there is an acidosis is because of hypoventilation. So causing this respiratory acidosis, when there is an increased PCO2, there is a hypoventilation, hydrogen ions are produced, which causes respiratory acidosis. This respiratory acidosis, it stimulates the arterial and the chemoreceptors, thereby compensated by hyperventilating. Okay, and when there is a hyperventilation, the PCO2 level decreases, thereby to an extent the carbon dioxide is pushed out and it reduces the acidosis. Okay, or the H plus ions are reduced. Okay, and the other systems definitely do come in action. The carbonic acid buffer and the renal compensation also comes into action. This is again a respiratory alkalosis. So when there is a respiratory alkalosis because of hyperventilation, what happens is there is an inhibition of the chemoreceptors, thereby reduced stimulation of the respiratory center, thereby retention, which causes hypoventilation and retention of carbon dioxide, which again increases the H plus ions, okay, which actually overcomes the respiratory alkalosis. And definitely other systems do that. Okay, so this is again an overview of the compensatory mechanisms which happen in the acid-base disturbances. So how do we, this is the thing that we are all worried about. So diagnosis of acid-base disorders. How do we work on it? Basically, we'll have to look at we need the ABG, okay, serum electrolytes. And with this, we will have to calculate the anion gap. And if the anion gap is present, I'll come to what is an anion gap in a while. So if we have an anion gap and also if it is a metabolic acidosis alone, then we calculate the delta gap. See, this anion gap is most probably useful in case of metabolic acidosis, but we can calculate in other forms, other acid-base disorders also. But in case if it is a metabolic acidosis, we need to calculate something called a delta gap, okay? And we'll have to look for the compensatory changes. So what happens, we take a acid-base arterial blood gas analysis. Directly, this measures the arterial pH at the PCO2. So ABG, when we measure, it looks directly into the arterial pH and to the PCO2. And bicarbonate on the ABG is calculated from the, as I said, from the Henderson-Hasselbalch equation. And it can also be calculated by the serum chemistry. Directly, it can be measured. Okay. And direct measurement is considered to be accurate than that of the derivation from the Henderson-Hasselbalch equation. So the most accurate measurement is basically from the ABG is the pH and the PCO2 in a ABG. So in an ABG, two things that we will have to see is the pH and the PCO2. Okay. So the normal values we will know is pH is between 7.35, PaO2 oxygen value ranging between 80 to 100 millimeters of mercury, PCO2 between 35 to 45, which we average is taken as 40, and HCO3, the gap, it's normally 24. It can vary between 22 to 26. And the saturation of oxygen values in the blood should be 95 to 100%. This is the normal values that we look at. Okay. So let us solve the question. Okay. Just there are only 4 steps in solving the equation. So simple it is. Okay. The first thing that we will have to look at is what is the pH? Okay. Is it between 7.35 to 7.45? If it is it, then it is normal. There is no acid-base disorder. But if the pH is less than 7.35, it means it is low, which means it is acidosis. Okay. If it is more than 7.45, it is alkalosis. There's no question about it. So with this, we move on to the next. What is that we look at? Because in ABG, there are 2 things that we'll have to look. One is the pH and the other one is PCO2. So assess the PCO2. What is the range between? It is 35 to 45. If the pH and the PO2, so this is where the room comes. Okay. If the pH, if we look at the pH and the PCO2, okay, if they go in an opposite direction, okay, what does it mean? It means it is a respiratory problem. Okay. And if there is no if it is not in the opposite direction, okay, if it is in the same direction, then we are not sure what it is. So then we assess the HCO3. Okay, HCO3 is basically, it can be directly measured from that is the accurate value from the blood that can be measured. And if PCO2 is not what we are expecting, as if it is not in the opposite direction, then we look at the HCO3. Okay. If it is metabolic, then the pH and the HCO3 should be in the same direction. Okay. Metabolic, they'll be in the same direction. So if PCO2 is in the same direction and HCO3 is in the same direction, then it means it is metabolic problems. Okay. Either metabolic acidosis or metabolic alkalosis. Hope it is clear. So if something is not clear, we just move on to a few questions so that we will be able to identify. Okay. I said the first thing is assessing the ABG. Okay. ABG, what is the pH and how is it? Okay. Identifying what kind of acidosis it is. So with the 4 steps, we'll be able to identify what kind of acid-base imbalance it is. Then comes the anion gap. What is an anion gap? It is the difference between the anions and the cations. Okay, that is sodium is a positive one. If you see sodium and the difference between the anions and the cations is the anion gap. Okay, so sodium minus the addition of chlorides and bicarbonates together is the anion gap. So usually anion gap appears in the lab testing because there are certain cations and the anions that are not routinely measured by the chemistry panel. So we are not sure. There is always a gap that is there. Okay, that we will have to measure. So sodium plus unmeasured, there are whatever we measure is a sodium. Okay, there can be unmeasured cations which is equal to that of the chlorides, bicarbonates, and unmeasured anions. Okay, so the cations along with the unmeasured cations is equal to the anions plus unmeasured anions. So this forms the anion gap. Okay, so predominantly the unmeasured anions are basically the phosphates, sulfates, and other negatively charged things. Okay, and predominantly the unmeasured cations. Okay, here whatever we have to find is there can be anions which is not measured, there can be cations which are not measured. Usually in the extracellular cations, the sodium, potassium, calcium, and magnesium are those ones which are not measured in the extracellular cations. So normally there is an anion gap which occurs. Okay, when we calculate, there is always an anion gap which occurs, which is approximately between 10 to 12 milliequivalents. Okay, this anion gap can be altered because of the unmeasured cations or the unmeasured anions. Okay, so these are the things which cannot be measured, which are not usually measured. So this anion gap is something which has to be measured, especially in case of metabolic acidosis. Okay, so when there is an increased anion gap, especially in the, this is most commonly seen in the metabolic acidosis, because the negatively charged acids like that of ketones, lactates, sulfates, or metabolites, like that of metabolites of methanol, ethylene glycol, or the salicylic acid, they are buffered by the bicarbonates. So the negatively charged acids, okay, they are buffered by the bicarbonate. And so this increased anion gap, okay, can happen in case of lactic acid acidosis, diabetic ketoacidosis, renal failure, toxins or drug intake, like that of methanol, ethylene glycol, uremia, cyanide, iron, isoniazid. All these things, there can be a high anion gap. There can be gap between the unmeasured anions and unmeasured cations. And sometimes even in starvation, this gap can increase. If anion gap is present, then we will have to measure the delta gap, which is nothing but the patient's anion gap we know, and we know the normal anion gap. So the difference between the patient's anion gap and the normal anion gap is called the delta gap. Okay, so this is all to look for what is the compensatory things that are happening. Okay, what is this? So basically, anion gap is very important in case of metabolic acidosis. In such case, when the anion gap exists, okay, when there is an increased anion gap, then we measure the delta. When there is an non-anion gap, when there is a non-anion gap that is present, then we don't have to calculate the delta gap. Okay, so let's solve the problems quickly. So this is a woman, 35-year-old female with AIDS, brought to the emergency with fever of 39 degrees and 3 months history of copious diarrhea. Okay, on examination, she was thin-built in moderate distress. Vital signs: pulse was 125 per minute, BP was 160, respiratory rate of 80, and was afebrile. The other examination was all normal except the bowel sounds were hyperactive. So this was the normal values. Okay, so the first thing that we will have to look for is the pH. What is the pH? pH is 7.35. Okay, it is onto the lower side. Anything which is less than 7.35 is acidosis. And the next thing that we will have to look at is when we look at respiratory, we will have to look at the pH and the carbon dioxide. So what is it now? So when we look at the PCO2 is 27. Okay, pH is low and PCO2 is also low. Normally PCO2 has to be 40. It is low. So pH is low and PCO2 is low. What does this mean? pH and PCO2, if it is low, it is on the same side. pH is low and PCO2 is also low. So this means it is PCO2, PCO2 is also low. So what we will have to do? So what is the basic abnormality that is noted? So here the pH is low, it is acidosis. Then PCO2 is also low. So in case of respiratory, it should be in the opposite. Since it is not in the opposite, it is in the same side. What we do is we go back to the, we go back to the bicarbonate. What happens to the bicarbonate? Bicarbonate, what is the normal bicarbonate values? It should be 24. So it is again low. So what does this mean? Bicarbonate is also low. pH is also low and PCO2 is also in the same direction. So this means it is metabolic acidosis. Okay, so the pH is low, the bicarbonate is also low, and the carbon dioxide is also low. So it is metabolic acidosis. Here, why is a metabolic acidosis happen? It's because of the loss of bicarbonates due to diarrhea that has led to metabolic acidosis. So, well, how do we calculate the anion gap in this? How do we calculate the anion gap? Anion gap is sodium is 136. So sodium minus the addition of chlorides and bicarbonates. Chlorides is 112 and bicarbonate is bicarbonate. Yes, so bicarbonate is 14. Okay, so 12 plus 14, 112 plus 14 is 126. So 136 minus 126 is 10. So what 10 is the anion gap. What is the normal value of the anion gap? It is 10 to 12. So here there is no anion gap in this. So what kind of metabolic acidosis is this? It is an non-anion gap metabolic acidosis. What is a compensatory mechanism that happens? Here, because of acidosis, increase in hydrogen ions, the carbon dioxide has to be pushed. So the acidosis is a strong stimulant which stimulates the respiratory center, causing hyperventilation, and this is what is called the Kussmaul's breathing. Okay, so Kussmaul's breathing is a compensatory mechanism of the metabolic acidosis. When there is a non-anion gap metabolic acidosis, we don't have to calculate the delta gap. Okay, hope it is clear. So this is how we exactly arrive at the what is a acid-base disorder. So what are the other causes of non-anion gap metabolic acidosis? It can be proximal or distal RTA, renal insufficiency, hypoaldosteronism, or potassium-sparing diuretics. And it can be loss of alkali due to diarrhea or ureterosigmoidoscope. Okay, so these are the other non-anion gap metabolic acidosis. We saw what are the high anion gap acidosis. It can be diabetic ketoacidosis, lactic acidosis, ethylene glycol overdose, the drugs. Okay, these are the things which can cause high anion gap acidosis. So coming to the second case, this is a 55-year-old female with a history of diabetes complaining of increased lethargy and fatigue over the past few days. She is obese, pulse is 76, her respiratory rate is 20, and BP is 160 over 98. She was febrile and her other examination was unremarkable. So we look at, the first thing that we look at is the pH. Okay, pH is 7.35. What does that mean? It is acidosis. Okay, acidemia, acidosis. Once we see pH is low, the next thing that we look at is the PCO2. What is a PCO2? Normally PCO2 is between 35 to 45. Here it is 22. So it is again in the same direction. So we look at the bicarbonate. Bicarbonate is again on the lower side. What is the bicarbonate value that it has to be? It should be 24. Okay, here again it is low. So all these things, the pH and the bicarb, if they are in the same direction, okay, what does that mean? It means it is metabolic. So metabolic acidosis is the acid-base disorder that is there. So pH is low, bicarbonate is low, so it is metabolic acidosis. When there is a metabolic acidosis, the next thing that we will have to do is calculate the anion gap. How do we calculate the anion gap? Sodium is 142 minus the chloride. Chloride is 105. The addition of chlorides plus bicarbonate. Bicarbonate is 10. Okay, so 142 minus 115. Okay, so that is equal to 27. 147 minus 115 is 27. So what is a normal anion gap? 10 to 12. So is there an anion gap here? Yes, it is an anion gap because here it is very high. So it's an anion gap metabolic acidosis. Okay. So when there is an anion gap, when there is a high anion gap, the next thing that we would have to look at is a delta. Okay, delta anion gap is the patient's anion gap minus the normal anion gap is what is the excess. This we would help in further looking at the other things like that of a compensatory mechanism. So if we know how to calculate the anion gap and that of delta gap exactly in metabolic acidosis, that is enough. Usually we would be asked to tell the what kind of acid-base balance is that. Okay, so just a quick review of thing. What are the anions that can cause this gap? Anion gap is basically in this the ketones, lactic acid, all those ethylene glycol, salicylic acid, all these things. So what is a compensatory mechanism for metabolic acidosis? This metabolic acidosis is again a strong stimulant of the respiratory center, thereby causing the woman to hyperventilate. So the hyperventilation would be a respiratory compensation for the metabolic acidosis. Hope it is clear so far. And the last question is that this is a 28-year-old female who presents with a complaint of muscular weakness and fatigue. She's lost 30 pounds since her last office visit 1 year ago. She has no other complaints and is on multivitamins. Her physical examination, she appeared fatigued, but blood pressure, pulse, respiration was all normal and afebrile. So here, what is the pH? pH is more than 7.35. So it is alkalosis. Basically, it is alkalosis. So let us look at what is whether it is metabolic or respiratory. Immediately after pH, the next thing that we look at is the PCO2. PCO2 is high. Okay, pH is high, PCO2 is also high. Okay, pH is high and PCO2 is high. So the next thing that we look at is the bicarbonate. Okay, so bicarbonate, what is the normal values for the bicarbonate? Normally it is 24. Okay, now this is high. Okay, so this pH and HCO3. If they are in the same direction, what does that mean? It is metabolic. So this is the acid base is a metabolic alkalosis. What are the predicted compensatory response? When there is a metabolic acidosis, preferably, usually all those systems come into action. And basically the first compensate, after the blood buffer, the respiratory compensation is by hypoventilation. When there is an alkalosis, there is less of hydrogen ion, so there is a respiratory suppression, thereby compensation of this hydrogen ion is by hypoventilation. Okay, so when there is an alkalosis, hypoventilation occurs, thereby carbon dioxide is retained and H+ ions increase. So this is exactly what happens as a compensatory mechanism of this metabolic acidosis imbalance. Okay, hope it is clear so far. I think you can work on few more questions, few more things so that you would be able to, it would be easy for you to work on these questions. And if you have not been subscribed to our channel, please subscribe so that you would be able to access more of videos and you would have you would be in touch with all these new upcoming videos. Okay, so thank you all and hope this video was useful. Thank you so much.